You know, when you read a marketing brochure for a modern cosmetic procedure, there is always this overarching promise of, like, total simplicity.
Oh, absolutely. The language is engineered to make it sound like, picking up a coffee or just getting a quick haircut.
Right, exactly. You walk in on your lunch break, you get a 15-minute treatment, and the bold print always says something like, return to your normal activities immediately.
Right, as if your body is just this passive canvas that won't react at all.
Yeah. But the moment you step out of that glossy marketing material and into the actual clinical reality of the human body, specifically the highly vascular, incredibly delicate pelvic anatomy, I mean, that illusion of simplicity just vanishes.
It really does. The pelvic floor is a highly dynamic, highly responsive environment.
Which is exactly why we're here today. Welcome to today's deep dive. Our mission today is to explore this fascinating contrast between commercial cosmetic promises and rigorous medical reality. We're looking into a highly specific clinical scenario, which is how medical professionals actually manage minor hematoma formation in the suburethral space following a procedure known as the G-shot.
It's a really remarkable intersection of elective enhancement and complex physiology.
It is. And to do this, we've gathered a stack of sources for you. We've got cosmetic clinic protocols, gynecological case reports, and peer-reviewed medical studies that detail both the injection itself and the standard protocols for managing vulvar and vaginal hematomas.
Because, things don't always go perfectly to plan.
Right. The G-shot is sold to you as a quick path to enhance sexual gratification. But what happens when that routine, seemingly effortless injection leads to a hidden internal pocket of bleeding? We're going to help you understand the precise, surprisingly hands-off, yet highly vigilant way clinicians handle this exact complication. So, okay, let's unpack this.
I think to really understand why a hematoma forms and how to treat it, we first have to visualize exactly what clinicians are doing during a G-shot and, more importantly, where they are doing it.
Yeah, let's start with the biological real estate.
That's the perfect starting point. The clinical approach to any hematoma is entirely dictated by its geographical location. So the G-shot, which was originally conceptualized by Dr. David Matlock, it involves injecting a dermal filler directly into the anterior vaginal wall.
And they're usually using, what, hyaluronic acid?
Yes, typically hyaluronic acid, which is similar to the formulations used in facial fillers like Restylane or Juvederm, or sometimes they use a specially processed collagen.
And the objective here is just purely spatial manipulation, right?
Essentially, yes. The clinician is aiming to project the Grafenberg spot downward into the vaginal canal.
Like pushing a button out a bit further.
Right. By injecting the filler, they are artificially creating a localized augmentation. Clinically, they target an area roughly the width of a quarter, projecting maybe a few millimeters to a quarter of an inch into the vaginal space.
Wow, okay. And I was looking at the marketing timelines in our sources, and they highlight that the physical injection phase takes about 8 seconds.
8 seconds.
It sounds so incredibly minor. But that 8-second window isn't happening in an empty void.
Far from it. The sub-urethral space, which sits directly between the vaginal mucosa and the urethra, is this dense, intricate vascular plexus.
Right, it's packed.
It's totally packed with a complex network of microscopic blood vessels and nerve endings.
It kind of makes me think of trying to retrofit a highly wired server room.
Mm-hmm.
You want to install a new piece of hardware in a very specific spot, but the walls and floors are just jammed tight with fragile fiber optic cables and power lines.
That is a great analogy.
If you poke a needle in there, you're bound to nick a pipe. Or a wire, I guess.
Exactly. You have a sharp needle navigating through this dense vascular web, so some degree of microtrauma is completely inevitable. A tiny amount of bleeding from the puncture site is expected, and clinics usually manage this superficial spotting by simply having the patient wear a tampon for 4 hours or so.
But the true clinical risk is what happens beneath the intact skin, right?
Right. If the needle traverses a larger vessel, if you nick one of those biological power lines you mentioned, and the vessel continues to bleed internally, you are no longer dealing with superficial spotting.
You're dealing with a hematoma.
Yes.
The blood has nowhere to go, so it just begins pooling beneath the surface. But reading through the clinical guidelines, I noticed that once this internal bleeding starts, the clinician's entire treatment protocol hinges on categorizing the severity.
They draw a very hard line.
Yeah, a line between a life-threatening catastrophic bleed and what they term a minor hematoma. So how do they objectively define minor when there is a hidden pocket of blood forming inside the pelvis?
Well, the clinical presentation of the mass itself gives them the first clues. The patient will typically develop a distinct blue or purplish mass that you can feel along the anterior vaginal wall.
And that comes with pain, I imagine.
Oh, intense localized pain and a really profound feeling of pelvic pressure. But clinically defining it as minor relies heavily on a strict size threshold and, crucially, the dynamic behavior of the mass.
The size threshold in the literature seems to hover around 5 centimeters in diameter, though I saw some protocols suggest you can monitor it up to 10 centimeters before upgrading it to major.
Yes, it varies slightly, but 5 to 10 is the standard monitoring zone.
But you mentioned the dynamic behavior of the mass. What does that actually mean in practice?
It means a minor hematoma must, by definition, be non-expanding.
Okay.
It reaches that 5 centimeter mark, for instance, and it just stops growing. The bleeding vessel manages to clot off, the internal hemodynamics stabilize, and that pool of trapped blood becomes entirely static.
You know, I've been puzzling over that exact mechanism for you guys listening. In such a highly vascularized zone, if you have a compromised blood vessel pumping out fluid under systemic pressure, why doesn't it just continue to fill the entire pelvic cavity? Like, what acts as the brakes?
What's fascinating here is how the body's own anatomical boundaries act as a first line of defense. It comes down to structural containment.
Structural containment.
Right. The sub-urethral space is bounded by incredibly strong, unforgiving fascial tissue. In that anterior triangle of the pelvis, you have boundaries like callus fascia and the urogenital diaphragm.
So we are essentially talking about a biological tensegrity structure.
Mm-hmm.
The surrounding tissues aren't just loose packing peanuts, they are rigid architectural walls.
That is a brilliant way to conceptualize it. These tough connective tissues act like a localized containment chamber.
Right.
So when the compromised vessel begins to bleed, the blood pools and attempts to expand outward, but it rapidly hits those dense fascial walls. The fascia physically restricts the deep expansion of the hemorrhage.
It traps it.
Exactly, it traps it. And as the blood continues to pool within that confined space, the internal pressure of the hematoma rises. Eventually, that trapped pressure pushes back against the bleeding vessel itself, creating this natural reverse pressure gradient.
So it's a biological tamponade effect. The body uses the trapped blood to crush the leaking pipe shut.
It creates its own internal pressure bandage.
That makes perfect physiological sense. But I have to ask, and I'm sure anyone listening to this who has ever dealt with painful swelling is wondering this exact same thing. If there is a trapped pocket of blood causing the patient intense pain and pelvic pressure, wouldn't the fastest, most logical fix be to just take a scalpel, pop it, and drain it right then and there?
It is the most intuitive thought process in medicine. If there's a painful collection of fluid, evacuate it.
Right, just let the pressure out.
But in the highly specialized field of urogynecology, especially when you're dealing with this specific vascular plexus, rushing to the scalpel for a stable mass is often viewed as the most dangerous maneuver you could possibly make.
Wait, really? The most dangerous?
Yes, and this is exactly why the gold standard for these minor, non-extending hematomas is strict conservative management.
Okay, so deliberately choosing not to cut into it. What is the specific danger of making just a tiny, simple incision?
Well, surgical intervention in an already traumatized, highly vascularized area introduces a cascade of new risks. To drain that hematoma, the clinician would have to inject local anesthetic, make an incision, manually remove the blood, and stitch it back up.
Right.
Every step is a potential hazard. You risk introducing external pathogens into what is currently a sterile pocket of trapped blood. But the overarching fear, the really big one, is the disruption of the hemodynamics.
Meaning you might inadvertently restart the bleeding that the fascial pressure just managed to stop.
Precisely. That fragile clot holding the blood vessel together is relying on the ambient pressure of the trapped blood. The second you make an incision, you release that structural tamponade. You lose the reverse pressure gradient.
So the clot just blows off.
It can easily dislodge, and suddenly you have reactivated the hemorrhage, but now you're trying to find a microscopic retracting blood vessel in a surgical field that is completely obscured by fresh bleeding.
Oh, wow. So you can take a stable, minor hematoma and inadvertently transform it into a major surgical crisis.
Exactly, one that might require general anesthesia and extensive suturing to fix.
Which completely explains the reliance on conservative management. But from the source material, this conservative playbook clearly isn't just sending a patient home with an ice pack and wishing them luck. It reads like a very active, tactical strategy.
It is highly active.
Let's list the specific steps they use. It seems to start with manipulating temperature and gravity.
Those are the foundational tools. Clinicians will implement aggressive cold compress therapy, so applying ice packs directly to the perineal area multiple times a day.
And that relies on the physics of vasoconstriction, right?
Right. The localized drop in temperature physically shrinks the diameter of the surrounding blood vessels to stop the bleeding. It helps secure that fragile clot and dramatically reduces the inflammatory swelling.
And they pair that with strict rest, or bed rest, which manipulates the hydrostatic pressure. By staying off their feet, they're removing the gravitational strain on the pelvic floor.
Exactly, keeping the local blood pressure as low as possible while the vessel heals.
And then there are analgesics.
Yes. The distension of those vaginal tissues causes significant pain, so clinicians rely on over-the-counter pain relievers, like ibuprofen.
They have to manage that intense perineal pain without giving them anything that might thin the blood too much.
Exactly, a careful balance.
I also noticed a physical intervention in the protocols called vaginal packing. What is that doing?
So sometimes they use sterile gauze to tightly pack the vaginal canal. By doing this, the clinician is applying direct physical compression against the anterior vaginal wall.
So it's an external reinforcement of the internal tamponade.
Yes. It presses the tissues inward, compressing the sub-urethral space to arrest any internal oozing.
I am kind of stuck on the aftermath of this strategy, though. Let's say the clinician successfully holds the line. The ice, the rest, the packing, it all works, and the bleeding permanently stops. You still have a mass of clotted blood, maybe 4 or 5 centimeters wide, sitting tightly packed in there. Does the patient just live with that forever?
No, they don't. If the clinician can maintain the stability of the hematoma, they just allow the body's own physiological cleanup mechanisms to take over.
Right.
Within a matter of days, specialized immune cells called macrophages infiltrate the site.
The cellular scavengers.
Yes.
Right.
These macrophages begin this arduous process of essentially eating the clot. They physically break down the clotted blood and cellular debris.
Wow.
It's slow, often taking several weeks, but the hematoma gradually softens, shrinks, and is completely reabsorbed into the system. The body essentially dismantles the mass molecule by molecule, completely making surgical risk unnecessary.
That is an elegant physiological solution. But, and there is a massive caveat in the literature here, this entire conservative waiting game requires intense vigilance. Because they aren't just watching the mass. They have to monitor for a very specific, localized anatomical threat.
Right, because of where it sits.
Exactly, it's sitting right next to the urethra.
The proximity to the lower urinary tract is the primary complicating factor here. As the sub-urethral hematoma swells, even if it remains within that minor threshold, it acts as an unyielding mass,
And it can physically press against the urethra, pinching it shut.
which leads to acute urinary retention. The bladder continues to fill, but they physically cannot void.
Which is incredibly dangerous. So the clinical solution I saw in the protocols for this is the immediate placement of an indwelling Foley catheter. Mechanically, I understand that you slide a flexible tube through the compressed urethra, it props it open so the patient can pee.
Right.
But our sources highlight that the catheter is also used to measure urine output in real time as a diagnostic tool to monitor for systemic internal bleeding.
Yes, it provides invaluable data regarding the patient's hemodynamic stability.
I have a major point of confusion on this, though. If a hematoma suddenly ruptures internally and the patient starts losing massive blood volume behind the scenes, wouldn't there be much more obvious immediate signs? I mean, wouldn't their blood pressure just plummet? And wouldn't they pass out long before a clinician notices a drop in a plastic catheter bag?
That is a highly logical assumption, but it actually underestimates the body's cardiovascular compensatory mechanisms.
How so?
The human body is remarkably adept at masking acute blood loss initially. If the hematoma begins to hemorrhage massively, the patient's overall blood volume decreases. To keep the patient conscious and prevent the blood pressure from crashing, the nervous system triggers massive peripheral vasoconstriction.
Okay, so the body clamps down its outer blood vessels.
Yes. It aggressively shunts the remaining blood away from non-essential areas and directs it almost exclusively to the heart and the brain.
Right.
Well, the kidneys are one of the first organs to experience this decreased perfusion. They receive less blood flow, and therefore they immediately slow down the filtration process.
So the kidneys stop making urine long before the brain stops getting oxygen.
Exactly. So a sudden drop in the urine output in that catheter bag serves as a stealthy early warning sign. It tells the clinician that there's decreased end-organ perfusion, which strongly implies there is a hidden volume loss occurring in the pelvis before the patient ever shows signs of clinical shock.
That is a phenomenal piece of biological detective work.
It really is.
But they can't just rely on secondary signs like urine. They also need to look directly at the mass itself, and they do this using bedside transperineal ultrasound.
Right. It's the ultimate non-invasive window into the space.
I was looking at the imaging protocols, and there's a heavy reliance on measuring the mass over time. They use calipers on the screen to compare the size, obviously,
Right, to ensure it isn't expanding.
but they're also deeply concerned with the visual texture of the mass on the screen. How does bouncing sound waves off a pocket of fluid tell a clinician how old the blood is?
It comes down to the physical density of the target. Fresh, active bleeding consists of liquid plasma and uncoagulated red blood cells. It's a highly uniform fluid.
So the sound waves just pass right through it without bouncing back.
Yes, and because no echoes return to the probe, that area appears dark on the screen.
Yeah.
The clinical term is hypoechoic, like a simple, dark cyst.
Okay.
But as the conservative management works and the bleeding stops, the blood begins to clot. It becomes structurally complex.
And because it's solidifying, the sound waves strike that clot and scatter.
Exactly. They bounce strong echoes back to the probe. The image on the screen becomes brighter and highly textured, which is termed echogenic.
So what does this all mean? It means without making a single incision, the clinician can look at the ultrasound and say, the calipers confirm the mass is still under 5 centimeters, meaning it isn't expanding, and the texture has shifted from dark hypoechoic fluid to a bright echogenic matrix, meaning it's successfully clotting.
It provides definitive proof that the conservative management playbook is succeeding.
But to summarize this, the clinician is essentially playing a high-stakes waiting game. They are holding the line, trusting the fascia and the ice packs, but they have clearly defined tripwires. What is the ultimate threshold where they abandon the conservative approach?
The surgical threshold is crossed the moment the clinical data indicates the body is losing the battle. If the ultrasound shows the hematoma is rapidly expanding despite the fascial boundaries,
Right.
or if the mass breaches that 10-centimeter mark, if the pain becomes completely uncontrollable, or, most critically, if that catheter output halts and the patient becomes hemodynamically unstable.
That is the absolute tipping point.
Yeah.
At that moment, the waiting game ends, conservative management ends, and they move to urgent surgical evacuation.
Yes.
But as long as those specific red lines aren't crossed, the ice packs and rest remain the best medicine.
Knowing the technical steps of a surgery is vital, but possessing the restraint to know when not to intervene, to let the body heal itself, is just as important.
As we wrap up this deep dive, I think that is the most resonant takeaway. Cosmetic gynecological procedures like the G-shot are marketed as simple, but the anatomy is anything but. When minor sub-urethral hematomas occur, the clinical art lies in restraint, using fascia boundaries, ice, compression, and careful ultrasound monitoring to let the body heal itself, rather than rushing to the scalpel.
Understanding these protocols really empowers you to see past the marketing brochures and appreciate the rigorous, cautious medical science required to safely manage the human body when things don't go perfectly to plan.
It really does. And that leads us to a final, lingering, provocative thought to leave you with, something for you to explore on your own. We've spent our time entirely focused on the local damage, right? The trapped hematoma in the pelvic floor. But we know from our sources that injecting hyaluronic acid into other vascular areas like the breasts or buttocks can occasionally result in stray filler particles entering the bloodstream.
Right. If the needle penetrates a vein, the material can travel directly to the lungs.
Exactly. And when it reaches the lungs, it can cause severe, life-threatening pulmonary complications like organizing pneumonia. So, if a post-G-shot hematoma proves just how easily blood vessels in the suburethral space can be punctured, could this highly vascular zone serve as the hidden superhighway for stray filler to reach the lungs?
It's a sobering question.
Is it possible that the true risk of a suburethral bleed isn't just the hematoma itself, but the microscopic filler particles that might have escaped into the patient's bloodstream in the process? It's something to deeply consider the next time you encounter a brochure promising a simple, effortless anatomical fix.